Sir, should we start, sir, now?
Yes, sir. I am starting. Good morning, everyone.
Yes.
Welcome to the Benign Pancreatic Diseases webinar by ESI Corporation Medical College and Hospital. First of all, I would like to welcome all of you to the webinar and thank the organizing committee headed by Dean Dr. Srinivas, Dr. Surat Patra, and others, and giving an opportunity for the TSASI to host it, and Dr. Jagdishwar Gaud and myself. And I would like to thank the speakers for agreeing to be part of this webinar. So without further ado, I would like to ask Dr. Surat Patra to start his presentation. Dr. Surat Patra is the principal and he is the man behind this webinar, organization and everything. So he's a HOD, General Surgery at ESIC Medical College, and he has worked in Navy before coming to the ESI hospitals. I request Dr. Surat Patra to start his presentation on pancreatic surgical anatomy and congenital anomalies. Thank you, Dr. Surat Patra.
Thank you, sir, for introducing me to the audience. Let me share my PPT desktop. Well, at the outset, I must thank ASI Telangana State Chapter for giving us this opportunity to host this webinar on benign pancreatic disease. As the moderator, sir, Professor Prasad has introduced the topic and the various speakers. It is shown in this slide, and we will have this sequence. Well, greetings from ESIC Medical College, Hyderabad. This is the main building, and this is another view. This is the super specialty center. And coming to my topic, the surgical anatomy and developmental anomalies of pancreas record. Just checking if it is recording. Okay. Now, pancreas, as all of us know, pan is all, creas is flesh, is all flesh, is a Greek word. It is divided into head, body, and tail. 80 to 90% is composed of exocrine acinar tissue. The weight is approximately 80 grams. Surgical anatomy. The pancreas is a bland appearing yellowish organ situated in the retroperitoneum. The very retroperitoneal location and the anatomic relationship of this pancreas combine to make its surgical removal difficult. Well, prior to exploration, the surgeon should know whether the patient's pancreas contains any anomalies of the parenchyma, anomalies of ductal system, and anomalies of vasculature. Anomalies of parenchyma like annular pancreas or pancreas divisum. Anomalies of ductal system like obstruction, aberrant location. Anomalies of vasculature like replaced right hepatic artery behind the pancreatic head or any other arterial anomalies. At operation, the surgeon must consider these possibilities even if they are not evident on preoperative imaging. The pancreas, as we all know, the pancreas lies transversely in the retroperitoneal space between duodenum on the right and spleen on the left. It is related anteriorly to the stomach, above to the omental bursa, below to the greater sac, as well as the transverse mesocolon. The pancreas is surrounded by numerous structures like duodenum, stomach, spleen, left adrenal gland, transverse mesocolon, colon, jejunum, left kidney, and right ureter. This very relation is making dissection of pancreas and around the pancreas potentially a risky to various multiple organs. This familiar picture, all of us have come across. The head lies within the curve of the duodenum. Over the body of the second, it lies over the body of second lumbar vertebra and vena cava. The aorta and the superior mesenteric vessel lie behind the neck of the gland. Coming off the side of the pancreatic head is the uncinate process, which lies behind the superior mesenteric vein. The tip of the pancreatic tail extends up to the splenic hilum. Exocrine pancreas, 80 to 90% of pancreas is exocrine pancreas, organized into lobules. The main pancreatic duct branches into interlobular and intralobular ducts, ductules, and finally acini. The main duct is lined by columnar epithelium and the ductules by cuboidal. This picture is self-explanatory. Cluster of endocrine cells known as islets of Langerhans occur in the pancreas, which constitutes of B cells, 75% producing insulin, A cells producing glucagon, D cells somatostatin, F cells polypeptide. The arterial supply, we all know. This is the picture which is self-explanatory. Venous drainage, this is for the sake of the UGs and PGs. The lymphatic drainage drains into 5 major groups. The anterior pancreatic duodenal group, pyloric lymph nodes, superior mesenteric lymph node, splenic lymph node, superior and inferior pancreatic lymph nodes. This shows the drainage of the lymph. Coming to the development of pancreas, on day 26, dorsal pancreatic bud arises from the dorsal side of the duodenum. On day 32, the ventral bud arises from the base of the hepatic diverticulum. Day 37, contact occurs between the two buds and thereby fusion by the end of 6 weeks. This has rotated, the ventral bud has rotated clockwise and the fusion has occurred. By week 6, the ventral bud produces the head and uncinate process. The ducts fuse, the ventral duct and the distal portion of the dorsal duct form the main pancreatic duct, which is called duct of Wirsum, and the proximal dorsal duct forms the duct of Santorini. By month 3, acini appears. By month 4, islets of Langerhans appear and become biological active. This depicts the development of pancreas. Duct of Wirsum, which is the main pancreatic duct, empties into the ampulla of Vata together with CBD. Then duct of Santorini drains into the minor papilla, approximately 2 centimeter above and medial to the ampulla vata, that is the minor duct system. Coming to the developmental anomalies of pancreas. Well, the variations in the pancreatic ducts, the duct system. This is the normal duct system, which is seen in 60% of cases. Well, there could be suppression of accessory duct, that is the Santorini, which occurs in 30% of cases. Accessory duct doesn't open into the minor duodenal papilla. This picture depicts that. Accessory duct doesn't communicate with the main pancreatic duct. This picture depicts that. Accessory duct in this case could be absent. Suppression of the main duct, duct of Wirsung, which is seen in 10% of cases. The accessory duct doesn't communicate with the main duct. Or it opens separately into the duodenum at major and minor duodenal papilla. This leads to pancreas divisum. Suppression of the main duct continues. The main pancreatic duct is absent. Here the main pancreatic duct is absent. Now the sphincter of Oddi. There are 4 sphincters: superior choledochal sphincter, inferior choledochal sphincter, ampullary sphincter, and pancreatic sphincter. Variations in the ampulla vata can also occur. Here there is a common channel with no sphincter mechanism protecting flow between the ducts. This sort of anomaly, they are prone for gallstone pancreatitis. The other anomaly could be there is a partial common channel. This sort of anomaly also prone for gallstone pancreatitis. There could be separation of the 2 ducts opening into the ampulla of the vata. The anomalies of pancreas can be summarized like aplasia, hypoplasia, hyperplasia, hypertrophy, dysplasia, ectopic pancreatic tissue, accessory pancreas, vascular anomalies, choledochal cyst, horseshoe pancreas, then variation of anomalies of the ducts, as I have mentioned earlier, pancreatic divisum, rotational anomalies like annular pancreas, pancreatic gallbladder, polycystic disease, congenital pancreatic cyst, cystic fibrosis, and von Hippel-Lindau syndrome. Little more about annular pancreas. Failure of complete rotation of the ventral bud, pancreatic bud, results this. The ring of pancreatic tissue surround the second or third part of the duodenum. This is associated with congenital duodenal stenosis or atresia, most commonly seen in Down syndrome, presents with duodenal obstruction, and as you know, the treatment is bypass. Duodenostomy. Well, this is the picture which shows how the annular pancreas occurs. Little more about pancreatic divisum. Most common congenital pancreatic ductal anatomical variant, dominant dorsal duct which drains through the minor papilla, and failure of fusion of the dorsal and ventral pancreatic duct occurs in this anomaly. The classic pancreatic divisum anatomy, the small ventral duct drains through major papilla, the large dorsal duct draining through the minor papilla, and there is no communication between the ventral and the dorsal duct. This is the picture. This is the picture of MRCP of the pancreatic divisum. This is gallbladder. This is bile duct. This is the long duct of Santorini crossing. Then short pancreatic duct opening to the duodenal papilla. Little bit of one for the benefit of the PGs and UGs. Von Hippel-Lindau syndrome. All these conditions, when they occur, like cerebellar hemangioma, retinal angioblastoma, renal cell carcinoma, pheochromocytoma, epididymal nodule and tumor, endolymphatic sac tumor, pancreatic endocrine tumor, and cyst. That constitutes von Hippel-Lindau syndrome. Well, there could be anomalous pancreatobiliary junction, APBJ. Anomalous pancreatobiliary junction refers to anomalous union of pancreatic and bile duct outside the duodenal wall. This results in long common channel outside the wall. This anomaly allows regurgitation between the pancreatobiliary and biliopancreatic duct. This is the picture. It's an enlarged picture of APBJ. Pathogenesis of APBJ, presence of anomalous pancreatic biliary junction seen in 90% of colorectal cysts. The APBJ pancreatic duct and biliary duct fuse to form common channel prior to opening to the duodenal wall. Pancreatic secretions reflux into the bile duct, which inflame and damage the biliary tree, leading to cystic degeneration. This is the X-ray and the ERCP picture of APBJ. The take-home message is pancreas is a retroperitoneal organ divided into head, uncinate process, neck, body, and tail. Detailed knowledge of anatomy and relation to surrounding visceral structures are important for better oncological outcome of pancreatic surgery, for that matter, for any pancreatic surgery. The knowledge of presence of various developmental anomalies of pancreas and the duct system is essential for the optimal management of benign pancreatic disease. Thank you so much, sir.
Thank you, Dr. Patra. It's a comprehensive talk on anatomy, development, and developmental anomalies of the pancreas. Thank you so much. If there are any questions, we will take.